Are you going to speak, Michael, or I have to start directly?
Please start, madam.
Yeah. Good evening, everyone, and happy to be on this panel discussion on launching a new molecule by Intas group, that is perampanel. And we all have used perampanel since last few years, and definitely we all have personal experiences also. So today what we plan is we will first have talks on the basic molecule and where does it stand and what are the strengths. And then we'll go to panel discussion where we will be discussing what are the uses, what are the personal experiences and where they prefer. But before starting the meeting, I would like to request everyone to have 1 minute silence because today we have lost our great neurologist, Dr. Ashok Pangadia. Okay, so may God give rest to his family and strength to his family, and may his soul rest in peace. So we go to the meeting today, and today we have very eminent speakers with us. First is Dr. Nandan Yardi, who is a great pediatric neurologist from Pune, and he's a very big name in ILA as in international as well as national epilepsy conferences and epilepsy CMEs. So today he's going to tell us on choosing the right add-on therapy in when and why. And I'm sure he's going to tell us a very good, method where we are getting few, because there are multiple AEDs available, multiple ASMs available. So what points should we consider when we are thinking of adding a new drug or a second drug or a third drug? So over to you, Nandan.
Sure. Let me share my screen. Can you see the screen?
Yeah. Yes.
Okay. It's been a very sad day today for neurology, as Dr. Sangeeta just mentioned that we lost our teacher, mentor, friend, and a very gentle personality, Professor Ashok Pangadia, and all of us have interacted with him because he was so friendly. He would come to you and talk to you just like a friend, and he's taught us so many things. So it's on a very sad note that we actually have been having this first webinar, with this news that is coming. But so may his soul rest in peace. I will be talking on positioning of newer anti-epileptic drugs in the treatment of epilepsy. And there are a few disclosures that, like some of you, Sangeeta, Joy, I've been a principal investigator for several drugs for US FDA approvals. And the outline of the talk is there a need for newer, better AEDs for epilepsy in general and childhood in particular? Positioning of the older AEDs, are they being displaced? The position of newer drugs, that is brevirastam, perampanel, the CBD oil, everolimus, fenfluramine, cenobamate, these are the two new kids on the block. And what do we mean by targeted therapies? So this is what I'm going to sort of cover in brief, just to give you a flavor of what's happening in our treatment of epilepsies. Am I clearly audible?
Yes, you are.
Yeah. So the choice of anti-epileptic drug is the single most important therapeutic decision that affects the patient's outcome and response. And when we look at, there are two types of anti-epileptic drugs. We all use conventional drugs ever since our residency days or student days. And we were taught, again, we recently lost Professor Alan Richens from UK, who did large work on anti-epileptic pharmacotherapy in the 70s and 80s, and he was at the forefront of telling us that monotherapy is the best. And everybody in the epilepsy world then believed that monotherapy should be tried. You should not have random combinations of anti-epileptic drugs just because one is not working. You work up the choose the best molecule for that type of seizure. So focal seizures, there were drugs which acted more on focal seizures, and there were other drugs which acted on generalized seizures or mixed seizure types. And they should be chosen in such a way that the best drug is chosen. If you choose the wrong drug, for example, if you choose a drug which acts on sodium channels in a case of juvenile myoclonic epilepsy or some generalized epilepsies, it could make the seizures worse. And therefore, we were taught that from our irrational polytherapy, we should go to monotherapy, work up the dose to its maximum therapeutic potential. That is, either the patient should have seizure control, good seizure control, or if he is not controlled, if he has side effects, that is the time to think of changing the medication. Till that time, we could go to the higher therapeutic or sometimes supratherapeutic dose of a monotherapy and try to get the best possible response. They thought that adding a second drug, and he was a proponent of that, that adding a second drug usually will not cause too much synergism. If you just add it irrationally, it will probably worsen the side effects. And then for the older drugs, like phenobarb, phenytoin, there were no randomized controlled trials really at that point of time. But with some of the others like carbamazepine, valproate, there were a few randomized controlled trials. And then polytherapy was not in fashion anymore. There were a lot of dropouts due to drug interactions and higher incidence of adverse events. At that point of time, we had the SANAD-1 study, which looked at comparative efficacy and side effects of carbamazepine, phenytoin, valproate, and they included ethosuximide, which was otherwise used for absence epilepsy. And they found that they were almost equally effective, but the side effects differed from one medication to the other. Then came the newer anti-epileptic drugs, and they all had to have RCTs, the randomized controlled trials. So they went through proper therapeutic trials on patients, and then post-marketing studies and results for all the newer anti-epileptic drugs. And really what was done was the anti-epileptic drug was used as an add-on to existing anti-epileptic drugs and compared versus a placebo, and the difference of more than 50% seizure reduction and the tolerability was looked at in these. Now, polytherapy again came back in vogue for the drug-resistant epilepsies after these newer anti-epileptic drugs. There was thinking that you could combine based on mechanism of action two anti-epileptic drugs which are differing mechanisms of action to cause synergistic or better outcomes from control of epilepsy. And when you do such a thing, then maybe you're not really increasing the adverse events as much as in an irrational polytherapy. So the rational polytherapy came forward. And then there were RCTs for monotherapy. And for example, tiagabine had failed in this, did not show too much seizure control, had side effects. And some of the felbamate and vigabatrin had serious adverse events. We all know that. Then with newer drugs coming in from the RCTs of monotherapy were lamotrigine, topiramate, oxcarbazepine, levetiracetam, gabapentin, which was a weak anti-epileptic drugs, zonisamide, and lacosam more recently in the past 8 or 10 years. And many of these were fairly effective in controlling seizures. Some of them had very peculiar side effects. Some of them had effects that were used to actually fit the therapy to the patient. So for example, if there's an obese patient, you could use topiramate because it causes weight loss, right? And then recently we have the SANAD-2 trial where primarily it was valproate versus levetiracetam comparison. And now in the recent times, there have been trials where they really don't use placebo so much, but it's more to show the non-inferiority of a new molecule as compared to the standard molecules that have been already established. So that was the change in looking at how the molecules have evolved. And the molecules have evolved, as we will see, based on different targets that have been found in neurobiology for as a reason why epilepsy occurs. And then because of all this, we got specific indications for drugs which we could choose. For example, vigabatrin was good in West syndrome, especially that caused by tuberous sclerosis. It is a drug of choice. Then stiripentol and topiramate in Dravet syndrome, lamotrigine in absence seizures, lamotrigine, topiramate, rufinamide in Lennox-Gastaut syndrome. Also, the clobazam was useful in Lennox-Gastaut syndrome. Levetiracetam has been shown to be good in myoclonic seizures, and perampanel in progressive myoclonic epilepsy. So there are very specific indications which came out, and these groups were these became the drugs of choice for the specific indications. So this was the backdrop on which there was an entire development of the anti-epileptic medication. Now we don't call them anti-epileptic anymore. We call them anti-seizure medications because they really probably do not affect the epileptogenicity, but act more as seizure controlling or reducing agents. So what happened was there was a shift in anti-epileptic drug use over time, and this was the Glasgow experience from Professor from there and Martin Brody. And as you see over here, between 1982 and say 1997, most of the drugs that were used were the standard 4 drugs: carbamazepine, valproate, phenytoin, clobazam, sometimes Gardinal, and in our country, Pinovab, which UK was not using at that point of time. But post 1997, you find that these newer colors, which are here representing lamotrigine, oxcarbazepine, gabapentin, levetiracetam, topiramate, all the newer drugs, lacosam, and other AEDs, their use have gone up significantly after the as they came into the picture. And this data which was presented till about 2014. So there has been a definite shift. And why has this shift been there in choosing these drugs? We will see as we go on. So these were the established drugs, and these are the new drugs. So why has this shift occurred? This is because now we have been learning as we go along to choose a drug based on the disease, based on the patient-oriented choice of drug. And on the patient-oriented choice, we look at physiological variables like age, sex, weight, comorbidities that may be there, concomitant drugs, quality of life, stigma, and other psychosocial variables. And from the disease-oriented choice of drug, we look at the type of epilepsy. Seizure types may be partial, generalized, undetermined, or multiple seizure types. There's the syndromes, that is a localization-related, generalized syndromes or undetermined. And then specific epilepsy syndromes, as we just discussed in the last slide, like West, LGS, JME, etc. And then we also look at EEG and other clinical features which tell us whether these are focal epilepsies or generalized epilepsies. And recently, as you know, the ILA has come forward with position papers on classification of seizures since 2017 and the classification of epilepsies. And now they are working on the classification of syndromes. So all these three put together have given us a lot of understanding, new understanding on epilepsies. And that's how we choose our drug based on all this and where our patient fits into this. And then when we choose the drug, we need to know the pharmacokinetics and pharmacodynamics of the profiles of the drug. Then we have to look at what was the evidence, whether it came from evidence-based medicine, what are the RCTs, or whether it came from meta-analysis or just guidance from expert opinions. Then we have to look at pharmacogenomic data and, of course, post-marketing clinical experience, which, of course, we will be sharing today. And all of you will probably share your experience regarding the molecules that you've used, especially perampanel, because this meeting is based on perampanel today. So that's how this shift has occurred. It's basically a change in our orientation of choice of drug. It was just not focal seizures versus generalized, and you choose a drug and give it. Now we think of so many things, and let's see how we do that. But what has happened, the snapshot of the time frame is that from 1985 onwards, when only carbamazepine, phenytoin, phenobarbital, were available, the number of seizure-free patients were about 40% and uncontrolled about 60%. By the time Kwan and Brody published their studies, and later in the year 2000, when some newer anti-epileptics, valproate and others started being used quite a lot, clobazam, what has happened is it has changed that 47% of patients were seizure-free, and with one drug, with the second drug added, you would get about another 13%. With the third drug added, you could get another 4%. So that a large percentage, almost 36%, was a small figure, which are not controlled. All the others are controlled, almost 64%. And then after that, in 2016, the further newer drugs came, and this has not really changed the picture too much. I think from 4%, this has gone by a couple of percent over here. So maybe a 3 or 4% changes have occurred. But what has really changed is the tolerability of the molecule. So we are having drugs which are much better tolerated, which have much lesser side effects. And therefore, that has been the major change. And we are evolving. We are using these anti-seizure treatments now. And we will start looking at anti-epileptogenic therapy and targeted therapies towards the end of the talk. So that's how the picture has changed. So how do we choose the second drug? So having chosen the first drug in monotherapy and giving it to the maximum tolerable dose till side effects occur or the seizure control occurs, if any of these problems are there for which we have to add or switch to a second drug, we look at what are the patient comorbidities. We look at a high therapeutic index drug with a high therapeutic index or a good tolerability profile. It should be from a different mechanism of action. So don't try to add 2 sodium channels over here. Try something else. And then those drugs known to have synergistic interactions in combination, such as valproate and lamotrigine, for example, they are known to be synergistic. So those could be added. So this is known as rational duotherapy. And this is what we move on if the monotherapy doesn't work. And you know now that choice by comorbidity, we said obesity, you can use topiramate or zonisamide. If there is migraine, you can use topiramate, valproate, zonisamide. If there are skin rashes, then go to levetiracetam or gabapentin. If there is neuropathic pain, pregabalin may be used, but it has been failed as an anti-epileptic drug. There are negative studies which we had done and published. If there's depression, lamotrigine is good, cognitive dysfunction, and so on. So you have to look at the comorbidities also and whether if your patient fits into any of these and move on from here in selecting. And the drugs to avoid in these situations are also given over here. So it's a good chart to look at as we choose the drugs. Now let's talk a little about the SANAD-2, which has recently been, there was an abstract which came out and recently the full study has come. And it has shown, the only thing one has to remember that it's really a randomized study to compare valproate and levetiracetam in generalized and unclassifiable epilepsy. And it's an unblinded randomized control study. So there's no blinding here. That's the negative part of the study. But it's a good study. And they look at time to 12 months remission, where they have shown that levetiracetam is not inferior. So they are using 2 very typically British way of putting it, not non-inferior to valproate, means valproate was found to be actually superior to levetiracetam. Time to treatment failure, valproate was superior. Treatment failure due to inadequate seizure control, valproate was superior. Time to first seizure, valproate was superior. You can look at the hazard ratios here, and that's how these conclusions have come. Time to 24 months remission, again valproate superior. So treatment failure due to adverse events, levetiracetam and valproate had no difference. So adverse event wise, there was not much difference, but clearly valproate has been shown to be superior. Now, when I was talking about mechanism of action of and principal targets, a lot of targets have been over the period of last 30 years described that lead to epilepsy in a particular patient. And there are these drugs, you all know this, I'm not going to go into too much detail. There's voltage-gated sodium channel in the neuron. Phenytoin, carbamazepine, lamotrigine, lacosamide, zonisamide, and oxcarbazepine act on this. The lacosamide is a slow sodium channel blocker of all these, and therefore there can be rapid sodium channel blockers and so slow sodium channel blockers. Sometimes they can be combined with each other, but if both are used, sometimes you have more side effects. Then gabapentin and pregabalin act on alpha-2 delta subunit of P or Q type calcium channels. Then levetiracetam and brivaracetam act on sp2a molecules. These are glycoproteins that sort of transmit the neurotransmitters into the synaptic cleft to act on NMDA receptors. Then reticabine has been found to act on potassium channels, felbamate on calcium and sodium channels, NMDA receptors. Then the glutamate that's released acts on NMDA as well as AMPA, and perampanel, which Dr. Joy will talk about, is a non-competitive inhibitor of the AMPA receptor and causes changes in sodium and calcium currents over here. So these are the various mechanisms, and these drugs have come in as anti-seizure medications, and we know how to choose them in what patient based on what we just discussed. So looking at brevirastam, SV2A protein is an integral transmembrane protein expressed in the secretory vesicles of neurons. So in the neuronal bodies, there is SV2A, and modulation of SV2A decreases synaptic currents in a frequency-dependent manner and reduces the readily releasable pool of neurotransmitters. So once the SV2A is acted upon, it reduces the release of glutamate in the synaptic cleft. And you can see in drug-naive or knockout mice, what happens is when you stimulate with low frequency, there's a lot of release of the neurotransmitter glutamate. With levetiracetam, when you have binding with SV2A, it reduces the number of glutamate reduced. And brevirastam being 15 times more powerful than that, when it binds to this more powerfully, there is even a much less release of glutamate. And this is supposed to be the mechanism of action in reduction of seizures. They all act through the NMDA receptors mainly. So what is the evidence of a stronger efficacy of brevirastam? I will not go into this, but there has been no head-to-head trials, and it is the best clinical evidence available so far. It worked in patients who had failed on multiple drugs, and it's worked in patients who had failed on levetiracetam because of efficacy. And those patients on levetiracetam who had side effects, psychiatric side effects or other behavioral side effects, had reduced side effects based on brevirastam. So brevirastam is positioned in today in such a way that if somebody is having levetiracetam and has failed levetiracetam, it can be used. If it is the patient has got a good response on levetiracetam and the patient has had as is showing side effects which are significant, especially the psychiatric or behavioral side effects, then it can be used, and it should be used in 1/10 or 1/15 the dose of levetiracetam. So if there is 1500 milligram of levetiracetam going on, you can use 150 milligrams of brevirastam. So the good point is that brevirastam it has a very good permeability and lipophilicity degree. So the permeability, what happens is it is very rapidly permeable and goes through the blood-brain barrier, almost as good as diazepam. Therefore, what's going to happen, and it's better than phenytoin. So in the management of status epilepticus, brevirastam injections may be a very good choice because they have a very rapid entry into the CNS. And we will wait for further studies on injection brevirastam for looking at its positioning in the management of status epilepticus. This is again the same thing showing in a monkey brain how rapidly the brevirastam has gone into the brain, and it has displaced the ligand 3 times as fast as levetiracetam. So it's even better than levetiracetam, which is slower to penetrate the brain. So it has a rapid onset of action. Almost on day 1 itself, you have a 50% seizure reduction. So this positioning is very good when you want rapid reduction of seizures. It does not interact with PGP transporters, so they may be less prone to develop drug resistance. It has a rapid and sustained action. So up to 84 months in our trials, we did follow up the patients for almost 8.5 years. And that has been one of the longest follow-up trials of anti-seizure medication. And we found that it remained effective even at 84 as compared to placebo in various doses. Efficacy outcomes have been good on brevirastam. Early and sustained response from day 1 is there. And early add-on makes a difference in reduction of seizures if you add it early on. So early adding of brevirastam has been proposed. And the safety data set shows that there have been not too many adverse events, and overall only 6% side effects are there with this, but major side effects may be somnolence and dizziness. Besides that, there are no major side effects. The behavioral adverse events are also less, as we discussed. And it can actually reduce the concomitant AEDs from 3 AEDs to 2 AEDs, as was shown over here in this study at 12 months. So it's been a very effective drug. It can be switched from levetiracetam to brevactizumab. We already discussed this. And in pediatric age group, it is still found to be effective on pediatric trials. The body weights related to body weight, this is what is given over here. So 0.5 to 2.5 mg per kg per day. In less than 20 kilos, more than 20 kilos, 0.5 to 2 mg per kg per day, and more than 40 kilos, 25 milligram BD to 100 milligram BD, depending on the severity of the medication and the weight of the child. Then I'm not going to look at this, the pediatric part. The perampanel is an excellent molecule. It's a selective non-competitive AMPA receptor antagonist. I'm not going to talk too much about it, but just skip through the slides because I know Dr. Joy is going to give a more detailed account of the molecule, its pharmacology, its positioning, and all that. But I'll just touch on the positioning of this. So partial onset seizures with or without secondary generalized seizures over the age of 12 years. Primary generalized tonic-clonic seizures in patients with epilepsy, 12 years age and older. These have been studied by us in these studies, 306 and 307 we did. And there are other studies which is 304 and 305. I'm not going to go to the details of that. But this received approval as monotherapy from July 2017 for treatment of partial seizures by US FDA. And it's been found to be a good molecule. I'm not going to go into this. It has a non-competitive antagonism of the AMPA receptors. And it is useful in all types of seizures, except in the absence epilepsy. The GAERS, those rats from Strasbourg, did not show effect. So absence epilepsy is not effective, but all other generalized and focal myoclonic and partial onset, it's effective. Then I'm going to skip all these studies. There's a significant reduction of all seizure types. But just to say that the secondary generalized tonic-clonic seizures are reduced maximally on this. So if somebody is having a lot of secondary generalized tonic-clonic seizures, it seems to be a very good drug of choice. So that is the real positioning of perampanel. The other positioning of perampanel, as we discussed, is in progressive myoclonic epilepsy. So I'll just skip all these slides because Dr. Joy will talk about them. And it is quite well tolerated, the perampanel, which also Joy will talk about. Now, what we still need, having had these newer anti-epileptic drugs, what is the need of the hour? We have anti-seizure medication so far, and what we need are something like really anti-epileptic medication, which will cause a modulation of the epileptogenicity, which will change the time course of the epilepsy and the comorbidities that are associated with epilepsy. And now we are looking at this. The treatment of therapy resistance is seen in 1/3 of patients, as we saw from the snapshot of the time frame of anti-epileptic drug development, and also from the Kwan and Brody studies. Of course, there have been some studies that have shown that Kwan and Brody studies are not absolutely gospel. There have been, and Joy will probably talk about this, and there are studies which have shown that there is significant improvement in small subgroups of different syndromes or different epilepsies when you try newer anti-epileptic drugs. So one has to try them and look for the response. And that response is almost very good for changing the quality of life of your patient. So that is the position of the newer drugs when you find resistant patients coming to you. So we cannot be desperate saying that, okay, 40% don't respond. We have to find a way, and some of them do. Treatment for difficult syndromes like Dravet, Lennox-Gastaut, and infantile spasms have to be developed. Improved options for newly diagnosed patients, like finding treatments that do not impact quality of life, modified release formulations, and other newer ways of drug release have to be looked at. Attention to comorbidities like depression, cognitive slowing, memory impairment. Some of these may be seen in as high as 30 to 40% of our patients with epilepsy, especially those having long-term epilepsy. And anti-epileptogenic or disease-modifying therapy, which I just mentioned. So the targeted therapies are those which are seen are developed to target specific parts or syndromes that are sort of caused by certain changes in neurobiology. Like these have been developed for Dravet syndrome. GLUT1 deficiency has to be sort of thought about, looked at, and SCL SLC2A1 gene, triheptanine can be tried, or ketogenic diet, of course, we all know. And triheptanine has been found to be very effective in GLUT1 deficiency. Ketogenic diet has to be lifelong. In CDLK5, they're trying to get targeted therapies. For tuberous sclerosis, we have everolimus, which is actually an mTOR inhibitor. And we will talk about the everolimus studies, and they have shown good outcome in tuberous sclerosis. For Rett syndrome, AVX S2 have been used on patients who are MECP2 positive. And in Lennox-Gastaut syndrome, again, there have been some work on targeted therapies. Let's look at Epidiolex trial, that is the CBD oil for Dravet syndrome. The safety is that adverse events is in more than 10% of Epidiolex patients, 84% show mild or moderate. So it can be used. What you get by using CBD oil is somnolence, diarrhea, decreased appetite, fatigue, pyrexia, vomiting, lethargy, upper respiratory tract infection, and sometimes even increase in seizures. Serious adverse events were 10 as compared to placebo, in only 3 of them. Discontinuation due to adverse events, there were people who discontinued, and elevated liver function tests were seen. All of them were on valproic acid. There are drug interactions of cannabidiol with clobazam, which we have to know. And at 5 milligram, 10 milligram, 20 milligram, you can see that the clobazam level increases to a certain extent, but the norclobazam increases significantly, which give rise to side effects. And whenever a child is taking stiripentol along with cannabidiol for infantile spasms, typically, those not taking stiripentol have a higher norclobazam level and than those taking stiripentol. So this we have to remember. So there is interaction with clobazam and stiripentol with CBD oil. So what is the efficacy in Dravet syndrome? For convulsive seizures, you find that there is a 39% effectivity of CBD in about 61 children that were looked at by Orin Devinsky and this group, versus placebo 13, and during the treatment period. And during the maintenance period, it seemed to improve a little bit. If you look at all the seizures, non-convulsive as well, then you still find that there is during the treatment period, there's a significant difference. So it seems to be relatively effective in both non-convulsive as well as convulsive seizures in Dravet syndrome. So again, if you look at drop seizures, there is significant improvement in drop during treatment and maintenance phase. And for the non-drop seizures, CBD versus placebo, you find that there is significant. So non-drop seizures, drop seizures, and all varieties of seizures do help, are helped with this. Then we go to the new therapy with this, which is everolimus. It's able to treat seizures while improving other tuberous sclerosis morbidity like facial angiofibroma, renal angiolipoma, giant cell astrocytomas have been reduced with this. We currently have a few patients who are on everolimus who have giant astrocytomas, and they seem to have stabilized. Some of the astrocytomas actually reduced in size as well. Maybe the first true anti-epileptic drug because it acts at mTOR pathway, which give rise to the epileptogenicity associated with tuberous sclerosis. The revolutionary trial was the EXIST-3 trial, that is everolimus for seizures associated with tuberous sclerosis. And this was by French, Lawson, and Riemann Nabu, and others. So basically what happened is that Afinitor, which is everolimus, acts on mTOR, and then it causes downstream effects of reducing the effects that lead to epileptogenicity. So what they did was they had a baseline period for 8 weeks. Then there was a double-blind placebo-controlled phase where there were 6 weeks of titration and 12 weeks of maintenance. The patients were 2 to 65 years who had tuberous sclerosis. So it was a large age group, broad age group, definite TSC per modified Gomez criteria, at least 16 treatment-resistant seizures per modified ILA classification were there. And they were on at least 1 to 3 anti-epileptic doses at stable dose for more than 4 weeks. So these were the inclusion criteria. They were randomized after that, after the baseline period of 8 weeks, into 1 into 1 into 1, 3 arms. One was AEDs and placebo. AEDs and everolimus, keeping the blood levels at a dose of 3 to 7 nanogram per ml, and AEDs on a higher dose of everolimus, 9 to 15 nanogram per ml. So there were these two everolimus groups, the moderate dose and the higher dose versus placebo. And you find that compared to the placebo, you have for both the groups significant improvement in the total seizures which are there. And then if you split them with the response rates, you find that few are 100% seizure free. There are some good numbers which are 75% seizure free, and there are others between 75 and 50% seizure free. So there is a good response, but many of them will have at least a 50% or more response over here. And if you look at the seizure types, you find that they are useful in focal motor seizures with retained awareness, focal motor with impaired awareness, focal motor with impaired awareness, and other focal seizures. So most of the focal seizures do respond to this quite well. So it is a good anti-epileptogenic drug. So there is a paradigm shift in treating epilepsies, looking more at the targets and developing drugs which act on these targets, which will modify the overall comorbidity and even cause seizure control. So that is the positioning for everolimus. Now, the two new kids on the block, which I mentioned, are cenobamate, and I'll just very briefly touch before I stop my talk. This safety and efficacy of adjunctive cenobamate, which was known as YKP 3089 in the trials, on patients with uncontrolled focal seizures, a multicenter, double-blind, randomized, placebo-controlled dose-response trial. These are fantastic trials which are designed very well. And they used week 1 50 milligrams, week 2 100 milligrams, week 3 150, 200, 300, and week 5 400 milligrams. This was the up titration following a baseline period of 6 weeks. There was a 6 weeks of titration in this fashion. And then these were maintained for 12 weeks. So these are the patients, various patients who are 100, 200, color-coded over here. And then at the end, they were blinded, conversion to open label extension at 300. All of them then went on to 300 milligram open label extension. And what we found that in the double blind treatment period of intention to treat population, the placebo was 24, cenobamate median response was 35, cenobamate 200 was almost 55, and higher doses also only gave 55, there was no increase. So 200 milligrams seems to be a good dose for cenobamate to give at least 55% of the patients giving 50% reduction. And maintenance, in the maintenance phase, this is also maintained. In the on a longer term in maintenance phase, 400 milligram may have a little bit 10% more improvement in the 50% seizure response. But now if you look at the 100% seizure response and 75% and 90%, you find that as compared to placebo, which is 10, 3, and 1 over here, you find that there's a significant percentage of patients who are getting a more than 75% response. So this is the first time that any new anti-epileptic drug is giving such a high complete seizure freedom, which actually is the need of the hour. So it tells us that cenobamate may be a very good drug to use in focal seizures. And this is from Pavel Klein and Gregory Cross and others from the Lancet issue of 2020, where they have described this trial. The last molecule which I will talk about is fenfluramine. It's a serotonin 5-HT releaser with agonist activity of, at the 5-HT2A, 5-HT2B, and 5-HT2C receptors. It's an appetite suppressant used in the 1970s for reducing weight, widely used in fen-phen combination for weight loss in 1990s, and withdrawn from the market because of pulmonary hypertension and cardiac valvular thickening, which we have to keep in mind if we use it. It was serendipitously found to be effective in a Belgian open label trial of Dravet, because they keep trying different drugs, and corroborated in a second open label study. Anti-seizure mechanism of action is uncertain. In vertebrate animal models with SCN1 fenfluramine has activity at 5-HT1D and 5-HT2C receptors.
Then we are running late, I think.
Yes, I'm just finishing the last.
Yeah, okay.
So potential additional mechanisms of action of fenfluramine affect receptor system beyond this, especially these delta 1 receptors. omega-1 receptors. Efficacy of fenfluramine in Dravet syndrome has been shown to be very good as compared to placebo. You see at least 70% patients show good response. And if you look at seizure freedom or near seizure freedom, you find that there's a significant, almost 17% patients getting seizure freedom on these doses. So the fenfluramine is used at 0.8 mg per kg per day, had also showed behavioral improvement. So this is where I will stop, and I think I have tried to give you an overview of the positioning of the newer anti-epileptic drugs. And now we go on to discuss with Dr. Joy the more specific molecule that we are interested in today, that is perampanel. And let's see where perampanel is sort of positioned in all this.
Yeah. Yeah. Thank you, Nandan. I think you covered all the newer molecules quite well, and we know what are the advantages and disadvantages of each of them. So now we go over to Joy, as we are running a little late. He's going to talk on the newer vistas in epilepsy management and the positioning of perampanel. And we all know Joy is one of the famous neurologist of South Bombay, and also a great epileptologist and a very good trekker and a very good friend. So, and also a good painter.
Thank you.
So over to Joy, and let's hear what you have to say.
Thank you, Sangeeta, for being very kind to me. And
No,
it's
I'm
great
always
to
kind to you.
it's great to have friends like you, Sangeeta, and Nandan. So I'm not here really to discuss new vistas and stuff like that. That's the title that Intas gave me.
Okay.
Basically, I think we are all gathered here because all the Indian companies, now that the original molecule of perampanel has gone off its period of patency, all the Indian companies are now manufacturing perampanel. And all of us, Nandan, myself, you, Sangeeta, and many others were part of the 306, 307 studies way back in about a decade ago when the pivotal studies were done. And since that time, we have been using perampanel discriminatingly in clinical practice. And we know that perampanel was approved in about 55 countries from 2012 onwards. And it's been here for a while. So what we have here is it's a once a day medication, and that's thought to be a singular advantage. We know that perampanel was available originally, and is available now as 2 milligrams, 4 milligrams, and 6 milligram strengths. And one can titrate gradually upwards, and we'll come to that in a short while. And the recommended titration originally, when the drug came out, was once in 2 weeks by 2 milligrams. And later, when the cognitive adverse effects appeared, the recommendation changed to once in 4 weeks or even once in 6 weeks. And if there is mild renal impairment, then no dosage adjustment is required. But in severe renal failure, if the patient is not on dialysis, then yes, perhaps the dosage would have to be reduced and perhaps to half. And in hepatic impairment, mild and moderate, there is no dose requirement. And by and large, the recommendation is not to exceed 8 milligrams in a day. And these slides that I'm sharing with you right now were the original slides that we actually used as investigators when we defended perampanel with my ethics committee. And many of these slides that I'm sharing with you originally were given to me by Eisai Pharma when we started doing the clinical studies, and we wanted approval for extended use on humanitarian grounds in some of our patients after the trials were over. Now, we know that it has a long half-life, 105, with no inducers, and with inducers like, say, carbamazepine, it comes down to about 25 hours. So that's an important pharmacokinetic property to understand. food does not seem to affect the absorption. About 95% is bound to plasma proteins. What we do know is that there is some metabolism by the CYP3A system inducers. It All of those can increase the clearance of perampanel, and that includes carbamazepine, oxcarb, and phenytoin. And therefore, one would have to bear this in mind when you are combining perampanel with these primary medications, which are very commonly used in the therapies of partial seizures. And of course, we always talk about hormonal contraceptives. And yes, on progestative containing hormonal contraceptives, it does decrease levonorgestrel exposure. And it's thought that perhaps there could be on perampanel at a higher dose, at about 12 milligrams, a prospect for oral contraception failure. Now, what we are here today, and you heard the exhaustive and all-encompassing, wonderful talk by Nandan on all the data that exists on the newer molecules, and there are so many of them today. We have post-levetiracetam, we got lacosamide, and then a lot of us started using that, and then came brivaracetam, and all the companies are vying for brivaracetam. I think we must have had 20 odd uh, webinars for brivaracetam, and now everybody wants to sell perampanel. So we really have to understand the core data of our drugs to some extent to help us embrace what it can actually do. So you heard about 304, 305, and 306 studies, and you can see that in the pivotal studies, Asia figured in 306. We were all a part of that. And the extension study was 307. Many of us were a part of that. And most of our understanding comes from that, but there were parallel studies being done in the US and other continents like South America and South Africa and Europe. And all of this data were actually collated together. And that led to a very large number of patients going on to the long-term extension, which is more than 1,218 patients who were on the long-term data. So what we know is that if we look at all the pooled analysis of all the phase 3 studies, then this publication came about when the drug was applied for approval by Eisai Pharma. And this is the data that we have in refractory uncontrolled partial onset seizures, those who are on more than 2 anti-epileptic drug combinations over the past 2 years and were on stable doses of at least 1 to 3 anti-epileptics and were having frequent seizures, 5 in a 6-week baseline, and never had a seizure-free period of more than 25 days. So these are patients with really difficult epilepsy, and they're the ones who got enrolled into placebo versus perampanel in doses of 2 milligrams, 4 milligrams, 6 milligrams, 8 milligrams, and 12 milligrams. And the responder rates were usual, 50% reduction, and there was some data later on 75% reduction, and the median change in seizure frequency and the median change in frequency of complex partial and secondary generalized seizures. You must have realized that these are the standard endpoints that the industry uses to submit data to the FDA for approval, because these are the easiest ones to handle in terms of statistical analysis and conviction garnering based on a drop by at least about between 30 and 40%. And the safety endpoints were the adverse effects, vital signs, and the usual ECG and labs. So if one looks at the demographics, they were fairly similar, placebo versus perampanel, and there was a good spread, 180 to roughly about 200 and 400 in different dosings of perampanel, a smaller number in the smaller doses of 2 and 4, and a larger number, as you can see, in doses of 8 and 12 milligrams. And if you look at the percentile of concomitant anti-epileptic medications, then they were fairly similar. So a good 85% of these were those who were taking 2 or 3 concomitant AEDs. And this is what the data showed, that if one looked at 8 milligrams, then there was a roughly 30% reduction in seizure frequency at 28 days. And at 12 milligrams, roughly it was similar, 27%. And if the median change from the baseline in seizure frequency at 28 days was again in that tune. But I think all of us should focus on the black bar, which is the 8 milligram bar, and look at the green bar, which is the 4 milligram bar. And you can clearly see what Nandan pointed out, that secondary generalized seizures were the ones which subsided the most in the pooled analysis, whereas complex partials did subside, but relatively less so, about 30%. And if you look at all of it, then the rough figure is close to 30% between 4, 8, and 12. So really speaking, the data in even in patients who were taking levetiracetam showed a similar frequency. But I'm not so sure how we should make a very big point about this, because patients with epilepsy are fairly diverse. And when we do studies of this kind, we often take the most difficult patients into the trial. And the only takeaway of relevance for all of us is that, yes, even in very difficult to treat epilepsy, it does make a difference. It makes a difference in suppressing partial onset seizures, and it makes a very big difference in suppressing their secondary generalization. So the numbers are between 30 and 60. And the finer figures you can always look up from the PDF of the publications. And these are the responder rates. And as again, we know that the best responder rates were for secondary generalized seizures, and for complex partial and secondary generalized seizures too. At 8 milligrams, you've got a good 35 to 39% responder rate, which is very, very heartening. And if one looks at the common adverse effects, then dizziness, somnolence, and headache, and then all the others, that everything that the patient complains of, nasopharyngitis, upper respiratory infection, and so on, get logged as an adverse effect, but they may not be of great relevance. Perhaps the key adverse effect, which uh, was given a lot of importance by the FDA, was hostility and aggression. And you can see that the patients in this table here, the patients who were receiving 8 milligrams and 12 milligrams of perampanel, in a good 12%, there was distinct hostility and aggression in the 8 milligram group and in 20% of the 12 milligram group. So the pooled analysis did support its tolerability and efficacy as adjunctive treatment. And it was the hostility and aggression bit that the FDA took great notice of, quite rightly, and put it up in a black box kind of warning. And the long-term safety of perampanel then was done, as I said, in more than 1,218 odd patients. And many of these patients had, and remember, a large chunk of these long-term follow-ups were of Caucasian ancestry with European, South American, South African, and North American bodily builds. And therefore, you had a maximum daily dose of 10 to 12 milligrams. I personally think that for our patients, I have opted for a lower dose than that, below 8 milligrams and below, and not above that. But we can talk about that in the discussion when the discussion comes up. So on the 307, which was the extension study, the conclusions were that long-term adjunctive perampanel did make a big difference in seizure suppression. The retention rate was good, 58%. The tolerability was consistent throughout, and there were no new safety problems over the extended period of time. And their seizure responses remained stable over years. And that led to, you all know Dr. Vincent Villanueva, who's been publishing real-world data from Spain for all newer molecules, including lacosamide, then perampanel, and brivaracetam. And this is again one such real-world data from Spain with fairly similar results. So these was an observational study in Spain, 18 Spanish hospitals, patients greater than 12, partial onset seizures, and perampanel as adjunctive therapy. And what do we have here? Figures that are absolutely similar to the figures we saw in the pooled analysis. So the median percentage of seizure reduction at about a year was in secondary generalized 75% and complex partial 30%, and all seizures roughly about 33%. And this is how the seizure freedom rates were. So they were also not bad, I would think, for difficult patients. At 12 months, the ones who were seizure free were about 10.3%, as you can see here. So that's pretty heartening that it actually does seem to benefit significantly when used appropriately and judiciously in correctly selected patients. And this was the data that came out from the real world experience, that if one were to widen the number of weeks that one used to escalate the dose, that means instead of weekly escalating by 2 milligrams, if we escalated by 2 milligrams every month, then the adverse effects clearly were very different. And you can clearly see that the black bars represent no adverse effects, the red bars represent adverse effects. You can clearly see that at a longer interval of titration by 2 milligrams, about a month or a little more, the adverse effects significantly drop. And I think that's what all of us need to understand, learn, and apply when we are using this molecule. So these were the guidelines. Scotland too, which has got its own guidelines, also approved of the use of perampanel in adults with partial onset epilepsy, and so did Hong Kong. And you know that now globally, perampanel is here to stay. And at that time, when perampanel was brought into the Indian market, the expert opinion consensus was that a slower titration is generally recommended. It can be reassessed gradually, preferably by a month or maybe a little more. Efficacy is similar in adults and adolescents, and adverse effects usually include dizziness, somnolence, and headache. And bedtime dosing is preferable. And of course, each individual uh, neurologist or epileptologist who's treating the patient can make his or her own choice when using this molecule, knowing the fundamental data. And there were, of course, publications like this one, uh, counseling that patients and caregivers should be counseled in advance about the potential risk of psychiatric and behavioral effects in patients who are on the higher doses of perampanel at 8 milligrams and 12 milligrams in uh, the usage that was done in the Western population. And do know that I showed you in the table that the figures for hostility and aggression were 12% at 8 milligrams and 20% at 12 milligrams, compared to just about 6% in the placebo group. So my own thinking about this is that, when we talk about hostility and aggression, then we ought to ask the question as to what makes us socially behave with decorum, and what makes us hostile as human beings when we are confronted with a change in the environment. So we have this model, and this is a model taken by, I have brought this out from neurobiology of psychologists. The model suggests that we have a top-down braking system, which is regulated by anatomical structures in the orbital frontal cortex and the anterior cingulate gyrus. And that seems to be our really important part of the neocortex that gives us stability, equanimity, and executive functioning. And we have a bottom-up drive that drives um, aggression, because ultimately we have evolved from animals and we are technically still animals. And these signals come from our amygdala and also parts of the insula. And all this is moderated by various lifetime and lifestyle associated inputs garnered over many years. So, uh, information processing, cognitive appraisal, stimulus and challenge, and reacting to provocation, all of that can be modulated by cultural, social factors, sensory distortions. For example, if one is on drugs and alcohol and we have metabolic disturbance, then obviously there is a sensory distortion. And if there is a comorbid cognitive impairment, like say paranoid ideation, conspiracy theories, because we have damaged neural networks in these areas of the brain, either damaged by acquired insults or damaged developmentally, then with or without sensory deficits like hearing loss or visual loss, then the threshold for aggression and hostility to come out will be greater. And we now know that this is also related to uh, the the prevalence and the persistence of different neurotransmitters in the brain, while serotonin and GABA have a differing modulatory effect on the cortical and limbic system. Glutamate and acetylcholine and norepinephrine and dopamine have a opposite excitatory effect. And these neurotransmitter changes will also reflect on how we behave in a given situation. So, um, the evidence-based review that was done by experts, and you can see Martin Brody in this and Bernard Steinhoff, uh, summarized the percentile data on the incidence of hostility and aggression in the clinical trials. And you can see that it's pegged at roughly between 3% and 20%, with the highest 20% being at a 12 milligram dose and 12% with an 8 milligram dose. And that is why the experts' view was that we have to look at this data very cautiously, because this is a diverse population of patients, and each neurologist could take his or her own choice in understanding the patient profile before making a choice about whether or not to use a drug like, say, levetiracetam or brivaracetam or perampanel, which we all know has the potential to alter that very fine balance in those very sensitive neural networks located in the anterior, frontal, and temporal regions of the brain. So, my own summary take home would be that what should we take home from all this barrage of information that I'm sharing with you? First take home should be that we should start low and go very slow. How slow? Maybe even a month or even 6 weeks if you feel like it, if the patient doesn't have very severe and very frequent recurring epilepsy and is willing to go slow. Therefore, and we choose the patient profile carefully. I would be very, very cautious in patients with a very large dysfunctional frontal and temporal network. For example, in patients who have bilateral post-encephalitic epilepsy, bilateral head trauma anteriorly from, say, motorbike accidents, bilateral mesial temporal sclerosis, or large swaths of cortical dysplasia. And it makes good sense to discuss the adverse effects in the clinic, weighing the pros and cons of the benefit versus the side effect, and then telling the family that in your best judgment, you think that this drug is likely to be beneficial with a very small but distinct potential for adverse effects. So if they observe that adverse effect and if they come back to you, then you could decide what final dose to actually use. And in my own experience, I found that even 6 milligrams of perampanel in a correctly chosen patient can have singular benefits and can help in reducing uh, dysfunctional and burdensome seizures in our very fragile patients. So I think I'm going to stop here. And I'm pretty certain that in the August audience that we have here, more than 40 at the last count, we could take up questions and people could share their own experience. We are very senior people here. Now I can see Dr. Haldar there. Uh, uh, People could share their experiences on how they see this drug. I personally think every drug is useful. We ought to know its best properties. We ought to know its worst properties, and we ought to know how to walk that fine line so that patient safety is not jeopardized. And thank you very much for listening. And I shall stop here. Sangeeta, the stage is all yours.
Yeah, yeah, it's ours, not yours. So thank you, Joy. I think both of you wonderfully covered the problems and advantages of parampanel and where we have to be careful. One more, I just wanted to add two things that now since it has this hostility and anger, this thing as a major side effect, we also have to be careful when we are combining with the drug which has a psychiatric side effect like levetiracetam and others. So that also we need to be careful whenever we need to. So I think now to take the panel discussion further, I would like to have people's opinion, their personal experience and which patients they have used, what dose and what problems they had. And second question, if they can cover is that whether they can, where will they place this drug if they want to use it as a first add-on, because now it is OD dose. It has got, cheaper in the market now. It is going to be the cost and easily available because the many companies will come up. So will their choice to change and use as a first add-on or not?
I wouldn't want to be first in anything, Sangeeta. I think there's no such thing. I mean, you use what will fit the patient's profile.
Yeah. No, I just want people's opinion whether what do they think about this? Okay, Dr. Haldar, we start with you.
Yes, when as I introduced it, it was expensive medicine, but anyway, I started using it. I found it's a very good drug if we keep in mind its side effects and all the criteria we need for a good anti-epileptic drug. It is there with this parampanel, except that we have to think of that absences are also that where we have to avoid it. But one problem I faced, the problem is, like lamotrigine, it takes 3 months slowly hiking the dose. So we have to wait 3 months, but a patient who is getting fits once in a month or once in 10 days, once in a week or every day, we just can't wait for 3 months. So there we have to avoid it. And this is I think, is the limitation of this drug. Otherwise, we keep, now since it's going to become a cheaper medicine, so it's a very good drug. That's what I believe. And another point I want to highlight is, I have seen, though the literature says that up to 12 milligram it can be used, but I found after beyond 8 milligram, side effects are very frequent over here. So that limitation also is there. Otherwise, it's a very good drug.
No, I agree entirely. Yeah, Joy, you wanted, please.
I just, taking up from what Dr. Haldar said, I have a kind of slightly different thought process also, and I just thought it'd be useful to share it with everyone. Even in patients, when we treat our patients, we know that there are some epilepsies where we are doomed to look after them for a very long time without the gold standard of them becoming seizure-free, because they have a large burden of epileptogenicity in their brain, or they have very large electrical disturbance constantly occurring in some of the generalized syndromes, for example. Give an example of Lennox-Gastaut. So we know that the natural history is difficult. Even in such patients, if we sit down and talk to their families and tell them that this drug is useful, it's going to take time. Yes, seizures are occurring, but anyway, the other drugs haven't done so greatly till date. I think it's useful to judiciously mix and match drugs with broad spectrum of activity. So valproate, lamotrigine, one of the citans, and even parampanel. And I often do that. So it's not an absolute no to use them in that group too.
But Joy, supposing now that there is it is approved as a monotherapy also. So in those cases, I don't know, I was thinking that maybe we can cover with clobazam for some time, till this drug builds up.
Yeah.
So that could be another option if you're trying to use it as a, because definitely if the patients don't get control, they are going to change the neurologist very soon. Yes, yes. So Dr. Bhaskar Roy, he's a neurosurgeon from Kolkata. What's your experience on this parampanel usage?
Oh, yes, thank you. It was an excellent discussion from both Nandan and Joy. Can I just take over a little from Dr. N.R. Halda from over here? That regarding. Hello? Yeah.
Dr. Kumar, Dr. Ashok, can you mute your mic?
Hello?
Yeah, thank you. Yeah, go ahead.
Am I audible?
Yes, go ahead.
Yeah. So what I needed to just point out, even while using lamotrigine, what we do before attaining the desired therapeutic level, well, it's never mentioned anywhere, but we have discussed it, and I am personally using it after, say, about 30 years of clinical practice. We add another molecule while starting, and after 4 to 6 weeks, we reach the therapeutic target. We remove the add-on molecule while which we initiated, then continue with lamotrigine, and in this case, perampanel also.
Yeah, same thing I was telling. Add clobazam for short time and then continue with the.
Exactly. In my case, I usually, I have used till date, along with perampanel, I have used levetiracetam.
Okay.
That's my experience. I've used very little, and to be very precise, till now, till before today's discussion, today's description, I have never used perampanel as monotherapy.
Yeah, and even we haven't used. I think that's the indication.
I think
just
tomorrow, from tomorrow morning, I'll be able to use it as monotherapy. Now, my question in my discipline to both Nandan and Joy. We encounter a lot of cases of FCDs, the cortical dysplasias, and very much lesions like peripherally situated large aggluted granulomatous lesions and all of that. I'm leaving aside MTLE. I'm just speaking of lesion epilepsy, and we go for lesionectomies. I'm not keeping of completely removing the hemispherectomy. No, I'm saying of lesionectomies. So how would you suggest this molecule after lesionectomy when we are, because usually in all the lesions which we operate, we operate only when the patient is on more than 2 anti-epileptics usually, because then only the patient can be motivated for surgery. In those cases, after the lesion, we see that the patient has, now we can reduce the number of anti-epileptics. So how would you suggest that after the surgery, we can gradually switch the patient to perampanel and continue with a single dose perampanel?
So Joy, you want to take that?
Yeah,
or shall I do?
It's a novel thought. I have actually not thought about that, and it's a novel approach that you've made us consider. Yes, so I think what Dr. Roy is pointing out is that the advantage of once a day dosing could make it a choice when dealing with such people. My own response to that would be that, when you see these lesionectomy candidates, before they've had the lesionectomy, they've already been, if they've had frequent seizures, then they would be on intravenously administrable anti-epileptic medications. So in today's world, what generally happens is that either it's levetiracetam or it's lacosamide, because both can have linear pharmacokinetics, can be given very quickly, and the drug levels can be achieved fast when you give it IV. And now, of course, we have brivaracetam wine straining at the leash, so to speak, for its place in the sun with levetiracetam. Now, in that kind of scenario, patients, once they have a lesionectomy, they're already on 2 good medications or 1 good medication. So then de novo to think about perampanel, I'm not so sure. I haven't done that so far.
Usually we don't change the medication post-surgery.
That
We
was what I was
continue
gonna say.
whatever pre-surgery, we continue the same.
I
And
would
you
not
know, they
change
are
it.
looking forward to us to get over those 2 medication also. So adding a new is very difficult for them to accept, you know.
Yes, I would agree.
I would say it like this, if I may, that you have first of all excluded MTLE, and therefore you're talking of extratemporal lesions and not hemispherectomy. So you're actually removing the lesion. So I presume that the patient has epilepsy with these lesions, and if the patient has epilepsy, then there is an epileptologist involved in defining the epileptogenic zone, and then you have removed the lesion. It's not just primary lesionectomy. Having said that, the patient has been treated with lesionectomy because he has epilepsy and because he has resistant epilepsy, and his seizures have not been controlled on the existing medications, which have been run up to its maximum dose. There several other medications may have been tried and all that. So if this is the presumption, and if you have really looked at the epileptogenic zone and successfully removed the epileptogenic zone, you really should not have any seizures with a successful surgery. Maybe sometimes you have 1 or 2 seizures immediate post-op, but they run down and then they stop. And therefore, we usually don't, and I think Sangeeta would probably also talk about this and correct me if I'm wrong, that we really don't change those medications that are going on. We continue them post-operatively for a significant amount of time. And eventually down the line, maybe at the end of 6 months or a year, we start actually thinking of reducing or even sometimes stopping the medication if the patient has completely responded. Of course, sometime 2-3 months down the line, we do reduce the dosage, because many times, as you said, they are on very high doses of 2, 3, 4, 5, sometimes 6 anti-epileptic. So we try to rationalize the anti-epileptic therapy at least after about 3 months. So that's how I would see. And if he's already on perampanel, of course we continue, but I don't think we'll add perampanel to a person who is likely to have lesser seizures than before after his surgery.
Okay. Right. So let's go to Dr. Keyur. What's your experience on the perampanel, and which patients would you prefer to use?
Thank you, Sangeeta. Most of the aspects of regular use of perampanel have been extensively discussed by Joy, and the experience is common that we use it in partial onset secondary generalized seizures, which are not adequately controlled and going very slow, 2 milligrams and increasing every 2 to 4 weeks. My experience has been to go up to 4 to 6 weeks, 4 to 6 milligrams, most of the times, very occasionally up to 8 milligrams. But I would like to share one experience about a patient of refractory status epilepticus that was not controlled on all the intravenous drugs available and was already on the pentosal infusion. And the seizures were continuing. There I had to use 24 milligrams of perampanel start and then 8 milligrams at night. And we could get off the sedation and pentosal. So that was a successful use of perampanel in status epilepticus. So that is worth trying in refractory status epilepticus. But there, unlike the regular slow titration, we have to hit hard, 24 to 32 milligrams stat.
Yeah.
Thank you.
There is a trial going on and there is some publication on high dose perampanel in the status epilepticus. We move to Dr. Meenakshi Sundaram. From Madurai. What's your experience and what's your take on perampanel?
Madam, I have only one slide to share for that, madam. Just allow me to share that. Just one slide, that's it.
Okay. Sure.
One or a couple of slides. That's all. Can you see my slides, madam?
Yes.
Okay. I'm a general neurologist and I'll share my experience. Thank you very much for inviting me for this program. So I've used this in one patient. I use as a third drug to a combination of oxcarbazepine and clobazepam. Very good benefit. However, the patient stopped after almost a year due to the cost.
So you can restart him now. The cost is going to go down.
And then one patient did not tolerate at all. He came back with severe dizziness. One teenager I used for a Lafora body disease. After reviewing the literature, he had a good symptomatic improvement. Now he is no more. 2 others, I did not have a great follow-up. And one of my patient was treated by my epileptologist, surprisingly for a presumable JME syndrome, and he gave very good feedback on this. And this was our own paper on super refractory epileptic status, and this was our use of perampanel in one of those. It was one of the molecules used by us. Of course, this patient did not have a great benefit. This was our very short experience on perampanel. I'm a general neurologist and I have not had a great opportunity to use it. Looking forward to using it more often because, as you have rightly said, madam, that the cost is going to come down. Yes. And on a passing note, I was one of the students of Professor Pangdia. I trained directly under him during my MD medicine, and we are one of the devastated students. He is always in our heart. And
definitely.
No words.
Yeah. Thank you. Thank you, Dr. Sundaram. I think it was very well shared, with accurate details on what's your experience. That's really nice of you. We move to Dr. Ashok from Patna. I think, can you just unmute yourself, Ashok, and tell what's your experience?
Oh, it's okay?
Yeah,
yes.
Sure.
Okay, well, so I have started in at least 10 to 15 cases in the partial, also in the generalized. One patient is on levetiracetam, clobazam. We have added 2 milligrams, then increased to 4 milligrams. She was a case of partial seizure and she is well controlled. And also case of the generalized seizure, they have also effect. If they are not controlled with 1 or 2 drugs, I have added as a third drugs. Among 15 cases, 6 cases have stopped the medicine because they have no benefit. And in the rest 9, at least 4 or 5 are very good control. They have no seizure, and other has reduction in the seizure. I think it is one of the, we have the drugs we can use after the other drugs. So it has benefit in 25 or 20% of cases, in my experience.
Okay. So that's true. Not that all patients are going to have benefit with this drug, and that's our experience also. There are some patients who do very well, and some patients we do have to stop. Now we go to Dr. Atampreet Singh. Is he there?
Yeah, good evening, ma'am.
Yeah, good evening. Good evening.
First of all, let me thank, I'm fine. How are you, ma'am? I'm good. I'm good.
Yeah.
Let me thank Dr. Nandan and Dr. Joy for a wonderful presentation. It was very clear and lucid. I think their experience and their, thoughts and all are very, actually, it enlightens you actually.
Yes.
So
thank you, Atam.
So yeah,
kind words.
Yeah. So we had few, maybe around 6 to 8 patients we had used recently in the last 1 year or so. 2 or 3 were actually partial seizure patients. One of them responded good, but other one actually had worsening of. He actually had something like a adult onset LGS like picture. So his drop attacks actually increased. So ultimately we had to stop that medication. And partial seizure patient responded quite well. Actually, they became seizure free after starting. And 4 or 5 patients we used for status also. They responded quite well. And once they responded, we started tapering perampanel also. So I think not a bad experience overall. Not much side effect in terms of dizziness or somnolence or behavior issues. I think not much. And some worsening, I don't know, but patient did not complain any worsening. So, so experience is pretty okay, I think. I think after the cost comes down and the new companies come in the market, possibly the experience also will increase.
And will also increase. Availability will also become more easy, because one company, often it used to happen, people will call you, now, madam, the drug is not available. Where do we go? Then we have to give phone numbers of the company's person and all that will go down.
Today I wrote for a child with late onset rest, 1 mg. Yes. So let's see how he responds. So let's wait for the response.
Right.
Thank you, ma'am. Thank you,
Atam.
Thank you.
So we now, Dr. Lakshmi Narasimha is there. Has he joined? Michael?
No, sir. No, madam. No.
Okay, fine. So Dr. Varun Malhotra? Okay. Dr. Ajit Cherian?
No, ma'am.
Okay.
No, ma'am.
Okay. Is Dr. Praveen Yadav?
Yes, yes. Dr. Praveen is there.
Yeah.
Thank you,
Ma'am,
ma'am.
Dr. Ajit is also available.
Ajit is also there. Yeah. Ajit,
Yeah.
please go ahead. Ajit.
Yeah.
They said no, so I read Ajit and I said, "Pata nahi kya ho gaya."
Madam, I have been using Parampanel for the past 4 years now.
And you must have used extensively.
Yeah,
I know.
I have at least 130 patients, 32 patients to be precise.
Right.
So we have a very good.
That's the biggest number I've heard of. Joy is also clapping.
So where I really started was basically when there was this a scarcity of bigger battery in the market. So that is when I started using it for the very refractory multiple tubers cases of tuberous sclerosis, and where they had bilateral lesions and LGS-like presentation, and the generalized tonic seizures, multiple episode being the hallmark. So I had excellent benefit with Parampanel at that time, and I used to go very slowly, 2 milligram, and in very small weight children, like less than 10, I used to start with 2 milligram alternate day, and then since 3 was also not available, I used to give 2 for alternate day instead of breaking the table. I used to give like that, and I have had excellent benefits with that. And since the tubers are nothing but cortical malformation, I started using in focal cortical dysplasias, FCDs 2B, the large FCDs which are very much close to the motor homunculus.
So can't operate.
Can't operate kind of stuff. So I got excellent benefit in that patients also. I have a huge list of them, and they could actually be taken out of the surgical list. And then I started using in the periventricular.
The surgeon will be unhappy then.
But we have a huge backlog of surgical cases. So we have a 2-year waiting period. And then started using in the bilateral periventricular node heterotopia cases, because they are also not operable. So these I have found that there is a cohort in this. Basically, these are the bad dysplastic lesions, because if you look at tubers, large focal cortical dysplasias and periventricular nodes, so they are basically part and parcel, siblings sort of stuff, basically, when you come to the histopathology. The other group which I had very excellent benefit was in the posterior head region gliosis with bilateral PHR gliosis, who present with generalized tonic seizures, like head nodding seizures or generalized tonic seizure. Because of the bilateral PHR pathology, they were also poor surgical candidates. So the take home was that this kind of generalized tonic, that is the crux here. So this Parampanel somehow the other how has a very good role. And I have quoted the Janssen's article, which has shown that AMBA-mediated glutamate excitotoxicity is the real culprit in this pathology. So
these are the ideal drug then.
Ideal drug to work. Then the other subtype is the startle epilepsy with a large parietal pathology, the startle kind of phenomenology.
Yeah, startles don't respond to anything.
Correct.
Good,
so
not even to surgery.
Correct. So there I have found very good response. And I have the list of where it don't work also. Basically, it doesn't work in eating epilepsy. I really don't know why it doesn't work in eating epilepsy. I've had poor outcome, because eating epilepsy is actually, because I have tried this in basically most of surgically failed or not suitable for surgery candidates. So that is where I started to say. And the pure mesial temporal lobe epilepsy, this is not a good one, because there is basically a hypermotor event, and so you need a generalized tonic kind of. So that is what the 5 data had shown. So that generalized tonic phenomenology, somehow the other how, this is where Parampanel really works. If that is not there, it doesn't work. And post-viral encephalitis also, it hasn't shown that much of remarkable.
So eating and post-viral encephalitis is not
and
working
pure
well.
mesial temporal, it doesn't do much. So
any experience on the IgE?
I haven't used. Basically, this was one question which was asked in the previous discussion also, because I have never had.
But there is a data coming up on the, that it's good in IgE.
But in
they say it's effective.
Correct, it's effective. But then I have never had an IgE who has not responded to a good dose of baseline drugs.
But you can try in PME, no? PME-like syndromes, you can try.
PME-like syndrome is one where we can actually.
But it's effective in myoclonus also. That's what they say.
Correct. So PME maybe we can try.
Yeah,
because,
we can
that
try
is not-
that. Right.
Yeah.
Okay,
this is-
so yeah, thank you, Ajit, for it.
Thank
Was
you, sir.
really enlightening, great and long experience on multiple pathologies. So now we move to Dr. Praveen Yadav. Can we have Dr. Yadav, please? Hello.
He was there actually, but I think.
Yeah. So can we go to Dr. Navajyoti? Dr. Navajyoti? Okay, he wasn't there.
Navu from Guwahati.
Yeah.
You're not there.
No, he's
He's there.
He had joined.
Joined. I think his mic is also on.
Navu is here. I can see him.
Yeah, he actually, his voice was also coming, but I don't know where is it gone now. Okay, then Dr. Dr. Vikas Sharma.
No, ma'am. I think he's not.
Okay, Dr. Saurabh Gupta.
Yeah, he is. Yes, he is available.
Dr. Saurabh Gupta.
Okay,
I think I'll go to the people whom I can see here. I think Dr. Saurabh Bilala.
Yeah, yes, ma'am.
Yeah, can you, Dr. Saurabh? I think they have put it on in the console.
That's the
yeah, Dr. Hasim. Dr. Hasim.
Absent seizure, madam.
Yes, ma'am.
Yeah, there.
Yes.
Yeah. Dr. Hasim, can we have your experience?
For the discussion. So my experience is around 15 patients, and to be very honest, I have not used it in as an early add-on. All these are like late add-on. Initially, when it came 4 years back, it was all desperate patient with non-surgical dysplasias, posterior head gliosis, that I have used with mixed result. So as Dr. Ajit Charin has said. So, and still I wonder, one thing is that now companies are pushing it as early add-on. But since there are a lot of competition there, so to be very honest, I don't see this molecule to be used as a first line or early add-on unless until more data emerges. Like we already have a gold standard carbamazepine, oxcarbazepine for focal epilepsy. Then we have levetiracetam, brivaracetam has come. Lacosamide is so easy to handle. Already we have lamotrigine, toporamate there, clobazam in add-on. So I see its use basically as an late add-on, and definitely for these kind of difficult epilepsies, many of these patients do respond. And good thing is that I have a few patients where drop attacks, generalized seizure has responded to focal seizure has remained the same. That also I had a young photographer who's like 35 years, passion of having photography. He had basically periventricular heterotopias, obviously not surgical, and he used to just fall down, and some brief focal complex partial seizures were there. So it could not get controlled with anything. So parenteral, touch wood for last 2 years, he has not got any generalized seizure, though he gets almost daily 5-6 brief non-disabling events. So that is one of the most
that is a big advantage, that secondary generalized seizures can be controlled.
On contrary, his behavior has improved, because he used to be very irritable, he used to shout at his father, everything is improved. So
maybe the seizures got controlled, so he's feeling better.
This is
Falls have stopped, so he's feeling better.
I also have a mixed response, but to be honest, all are like late add-on, but I am not able to place it as an early add-on. Even my next patients, even the price drop ability is there, because now we are spoiled by choices. So we have too many choices to choose from. So still, I just want your seniors comment with whether are we seriously looking at it as an early add-on, because company will keep on pushing, because once the early medicines fail, we are probably left with a bad denominator. So any medicine is not going to work there. So every company has interest to keep their anti-epileptic medicine early. So that, but
probably it will come only after an experience for a long time, and we ourselves become confident about it. Yeah.
Both add-on, I'm not able to place before that.
Right. So thank you, Dr. Hasim, and we go to Dr. Vinod Rai.
Thank you, ma'am.
Yeah,
Ma'am, I have
hi.
very little experience, nearly 10 patients I have used, but there are 2 patients in which I have seen a kind of dramatic response. So one was a super refractory status epilepticus, and that patient obviously on multiple infusions, but I added, after adding perampanel, we can clearly make out that it has worked, and gradually it was controlled. And second patient was NMDA encephalitis lady, and it was used as a third add-on, and within I reached up to the 6 milligram dose, and but there was so every day there were about 30-40 seizures in a day in that lady. But ultimately, after adding perampanel that was available with the name of Fycompa at that time, and gradually the seizure control was achieved.
So I think there are a lot of people having good experience in the status and uncontrolled status, I think. So
yes,
that's a good thing. Thank you, Dr. Rai. Can we have Dr. Badresh? Dr. Jabin?
Dr. Jabin, yes.
Yeah, Dr. Jabin?
Madam.
Madam.
I'm hello, good evening, ma'am. Good evening, everyone.
Good evening.
I actually was a part of the study,
right.
phase 3 study and lateral extension study. And that's why we had to continue perampanel in a lot of patients, because they really worked. It really worked in many patients. So when recently after the drug was available, when I analyzed the data and we presented also in the meeting, there were 35 patients whom I have used perampanel, and 50% seizure reduction was seen in 60% of the patients. And some patients, like 25% of the patients, became seizure free completely. So this is my experience, and I have found more useful in posterior cortex epilepsies, where most of the drugs do not work. And I think it should be used more with valproic acid and zonisamide rather than with carbamazepine or phenytoin, because these are drug inducers and you may have to use higher doses of perampanel. So I found it more useful when you use in combination with the valproic acid and zonisamide.
Any experience, Dr. Jabin, on generalized IG genetic epilepsy?
IG I have not used, madam. Most of them become seizure free on valproic acid with lamotrigine or lamotrigine with levetiracetam. I have not tried, but PMEs at least 4 patients have tried, and it really is helping the patients.
Yeah, thank you, Dr. Jabin.
Behavioral effects
any side effects? What's side effects?
Side effects are a problem once we crossing 6 milligrams.
Okay. So what's the dose usually you have used in this patient?
I have used mainly 4 and 6 milligrams. I usually start with 2 milligrams and hike up the 6. I don't treat most of pediatric epilepsies are less compared to adult epilepsies. But I think pediatric epilepsies 2 to 4 milligrams should be sufficient.
Right. Okay. Thank you, Dr. Jabin, for is Dr. Saurabh Vilala there? Dr. Badresh? Yeah, Dr. Badresh. Yeah. Dr. Badresh, please share what's your experience on this, and where do you place as first, second, third add-on? Where do you place it?
Actually, madam, I have used second and also third, and in refractory epilepsy and status epilepticus. I have used more than 25 patients, Isai Pharma, Fycompa. So even status, it was. Do you have anybody has experienced that we generally start with the high dose? Because I have started high dose, patient was comatose, and then he recovered venous sinus thrombosis with status epilepticus. And I have used also in children more than 8 age. Actually, it is recommended less than more than 12 years, but in 8 years. One was the patient who has gone everywhere, AIMS, Chitra, Bombay. But I thought that the mechanism is different. And I added as a 5th drug, even, and he responded very well. And he's on 6 milligram Fycompa at present, but there is no problem. So the status epilepticus, then But that is I use generally in focal with generalized epilepsy, rather than only primary generalized epilepsy. But the combination is generally I use with levetiracetam, brivaracetam. That are the favorite molecules. Otherwise, I don't have use in phenytoin with carbamazepine, all these drugs.
Yeah, thank you, Dr. Badris.
I have to ask some questions.
Yeah, please
Anybody, the spatial population that should be discussed, the pregnancy, breastfeeding.
Pregnancy. Not yet approved. It's still category C. Yeah, still category C.
Yeah.
Even brevitiracetam and this parampanel, both we have to wait for the pregnancy registry and see whether we can get the approval. Currently, no.
And hepatic renal failure and elderly patients, these are some specific populations.
Yeah, Joy, you want to take this question?
One needs to also understand. I think we are missing the tree for the woods. Carbamazepine, phenytoin, if one is using as a primary medication or oxcarb, I brought that out in the slide that I showed you. If one is using perampanel, we should understand that they are all enzyme inducers, and they will increase the clearance of perampanel. So the lower dose that we use with the other newer medications, you might have to give a better dose. Perampanel has been shown beneficial in trials in progressive myoclonic epilepsy. So that's one clear group.
Joy, he wants to know hepatic and renal and elderly.
Yeah, I would hesitate to use perampanel in patients with end organ dysfunction, because the data clearly implies that in mild end organ dysfunction, it has no dose change necessity. But in moderately advanced ones, it's a extensively protein-bound drug. So we know that with renal disease and hepatic disease, protein dynamics become completely abnormal. So I would hesitate to use it there.
Okay.
So, if I may add to that to directly answer his question, in hepatic, like Joy said, in mild hepatic failure, do not need to change the doses. But with moderate hepatic failure, already it has a very long half-life, of 105 hours. But even in moderate hepatic failure, it can go to around 295 to 300 hours. And therefore, the toxicity can occur. So one has to be very careful.
Very careful.
Not so much in the renal, can be used in renal. Yeah.
Thank you. So we move to, thank you, Dr. Badrish. We move to Dr. Vimta Raj.
Dr. Vaikunta Raj.
Vaikunta Raj.
Yes, madam. So good evening. I'm a pediatric neurologist. So I'm using perampanel quite commonly because you will see most commonly pediatric patients with refractory epilepsy. The most unusual thing in pediatric is you will see a lot of epileptic spasms. And you use quite commonly this drug, even though it is not approved less than 4 years. But only thing, many of them will respond compared to newer drugs like brivaracetam. The response for epileptic spasm is good. And only side effects you will see is the drowsiness is the main common thing, even if you are using 1 milligram per day. This is our experience.
Right. Good. So I think Nandan, you want to add anything on this pediatric thing?
Not really. I think he's already shared, and we have another pediatric neurologist, Dr. Vilas Jadhav. So if you can ask him at this moment, it will be the right
Vilas.
thing to do, I guess. Yeah.
Vilas, are you there? Dr. Vilas?
He should be there. I think it's.
Hello. Yeah, can you hear me? Yeah. Hello. Nice. Yeah.
Show your video also. Let us see you.
Yeah.
Unless you are not dressed well.
I totally agree with Dr. Vaikunta and Dr. Nandan about this. I have been using this almost for 5 years now. 4 years, I would say, since it's in market. My inclination of using the drug, I had one child with a CDKL5 mutation. And there I used as a precision medicine, because it is a glutamic receptor disorder where both AMPA and NMDA channels are at work. So I used it in, that's only one case as a precision medicine. I don't know, I mean, if Dr. Nandan or Dr. Vaikunth have used in CDKL5. So that child had severe spasticity also, and she had autistic features, a girl. And she had intractable seizures, poorly controlled, almost 3-4 drugs. And when we got the result of CDKL5, this was in, I think, 2016. So that time, just Firecompa had launched 18, I think. And from that day onwards, almost now 4 years, she had only thrown 2 or 3 seizures.
Oh, that's
Before
very
she
good
used to have
response.
almost, one in a week, more than that. And her autistic features may be age-related. I'm not saying because of perampanel, but she's little less autistic than the previous. That's one thing I wanted to share. Precision about this specific, my inclination is I use it in intractable waste, the epileptic spasms, where I don't get any response to the another bicarbacterial ACTH and zonisamide, of course. And the fourth drug is perampanel I use, where I have almost 3 kids doing pretty good on perampanel. That's number 2 where I've used quite often. Number 3, I have started using as a anti-NMDA encephalitis, especially children's fall after that autoimmune encephalitis, and it has given mixed result. I won't say good results, but it is where the place I think we should try there as a in pediatric cases post NMDA receptor encephalitis.
Yes, yes.
And then the rest of all the intractable epilepsy. But these 3-4 things which one should keep it in mind. I read one report of ATAD mutation. Again, it's a precision medicine. I've never had a single child with the ATAD mutation where perampanel works beautifully. Beautifully means that's like a precision medicine.
So I think more precision medicine also we have some focused indications for this perampanel. Definitely, that I think we need to keep in mind because we are using genetic studies now in more and more patients.
Yes.
Yeah. Dr. Vikas Sharma is there? Is Dr. Vikas Sharma? So, Rahul, do I miss anybody now or?
Ma'am, Dr. is there.
Who? Doctor?
Rupesh Senapati.
Yeah, Dr. Rupesh Senapati. Can we have you? Your experience, please. Dr. Rupesh?
I think he's not able to switch on his mic, ma'am.
Okay, okay.
Dr. Narendra Kumar.
Dr. Narendra Kumar? Dr. Narendra Kumar?
Ma'am, I think we have covered everybody.
We have covered? Okay.
Yes, ma'am. Yes, ma'am.
Yeah, yeah. So anything on closing note from Joy and Nandan?
No, I think we've had a good evening. It's rather late in the day. So you are the queen bee. So the queen bee should have the final word.
And I think we had a very good sharing from everybody, and with the
personal
experiences, that has really
you...
enriched the whole sort of webinar today.
That only makes us more confident.
Exactly,
and I think Ajit, your suggestions were really, and
Ajit was outstanding.
Yeah,
Madam, I have 2 slides. Can I share that?
Yeah, please go ahead.
I'll just summarize my experience of perampanel. Can you see this?
Yeah, I can see the slide. Just make it full screen.
Yeah, I'll just make it full screen.
Super.
Okay, this is my experience of 132 patients. These are the subgroups where I've used it. All types of dysplastic lesions as well as PHR gliosis, tumoral epilepsy, vascular malformation, post-insulin. I've used in almost all the subspectrum. So I'll just concisely tell where I have found that it works well. So I've used it, especially in pediatric adolescent, young adults, earliest as a second IR. Usually after lamotrigine and valproate, this has become my chosen drug, sort of.
Okay.
So the best results I have noticed is in perinatal insult PHR gliosis tonic seizure. That is the one which has given me the best
So
results.
that will really give a bit good, because that's a real problematic group which we,
especially they present with LGS like phenomenology, bilateral, they are not surgical.
And not surgical.
So tuberous sclerosis, where you have tubers on either side which are active, large dysplastic lesions which are very much near the
motor cortex,
motor cortex or
eloquent cortex,
eloquent Broca's area, something like that. Patients with a tendency for hyperammonemia on hiking, topiramate or valproate or zonisamide or lamotrigine. Actually, these patients, we are at a disadvantage to hike these drugs up. What I have found is that when I have reduced these drugs and I have added the parampanel, for some odd reason, I have found very, very good results. So this is
that's an excellent thing. Today only I had a girl with hyperammonemia, and we admitted because multiple drugs and valproate. You have to stop for 24 hours because.
Correct. I have had so many patients who have had this one. It is just a serendipity that I found this out basically, and I get very good results on this one.
So I will surely try this.
Patients who have shown at least some kind of response to topiramate. This is a clinical group because topiramate has an anti-glutamatergic effect. So if there is some effect to topiramate, they will show a better response to parampanel. So that is something which we need to look at. And reflex startle epilepsy, especially to large porencephalysis.
You touch and they fall,
Correct, exactly. So these patients also do well with parampanel. Now, I'll just show you where parampanel may not work also. I'll just, okay. So, okay, where the parampanel may not work is basically the ones which I've already told, the eating epilepsies, the DLEs, the MTS. I have, that slide is not there currently. So the MTS and the ones which are post-viral encephalitis patients, and where they have hypomotor events are the crux, hypomotor. They don't respond that well to parampanel.
So for you're saying those who have a tonic seizures, those who fall, these are the patients who are really helped by this parampanel.
Really helped by these drugs. No doubt.
So I think this is really enlightening. Right, Joy, and I think we can really use in this patients because excellent, Ajit, for sharing this experience.
Thank you.
Yeah. So with this, I think we come to end of this session. Michael, you want to take over, and I think Joy and Nandan for excellent talks, and all the participants for sharing their valuable experience, because unless you use it yourself, you are not going to be confident of this drugs, how good it is and how bad it is, and where you have to be careful. So I think we have covered lots of minor points where how you have to go, which patients to choose, where not to use. And I think this will really help us in future on having a judicial use of this drug to get the best result. So over to you, Michael.
Thank you very much, Madam. On behalf of Astera Intas, I would like to thank you, Dr. Nandan Yardi, for your very exhaustive insights on the newer AED placements, and as well to you, Dr. Joy Desai, for your lucid presentation on parampanel, which was perfectly useful in today's clinical setting. I would like to thank you, Dr. Sangeeta, for moderating this entire program so well. I wish to thank the entire galaxy of illuminaires as panelists for sharing their clinical experiences, namely Dr. N.R. Halda, Dr. Bhaskar Roy, Dr. Ashok Kumar, Dr. Keyur Bush, Dr. Meenakshi Sundaram, Dr. Atampreet Singh, Dr. Ajit Cherian, Dr. Hasib Hassan, Dr. Vinod Rai, Dr. M.S. Jabin, Dr. Badresh Mangukia, Dr. Vaikanta Raj, and Dr. Vilas Jadhav. Thank you all for sharing your wonderful clinical experiences that has helped the more than 500 doctors who are present in today's webinar and has enlightened all of us. Thank you very much to all. And I would like to reiterate that we are always in the forefront of such academic initiatives for the benefit of mental health care. Thank you one and all. Thank you for making such a wonderful and enlightening evening. Thank you.
Thank you. Thank you, everyone.
Thank you all, and stay safe.
Good night.
Thank you. Good night.
Thank you, ma'am. Thank you, sir.
Thank you.
Yeah.
Thank you. Bye.
Thank
Take
you.
care.
Good night.